Hey colleagues, if you are a mental health professional but feel like you don't have an understanding of the basic medicines that are used to treat common mental illnesses, then listen up, because in this series we're diving deep into psychopharmacology for therapists. Welcome back to Psychopharmacology for Therapists. In this series, we're exploring the most common medications in mental health with added therapist commentary to help mental health providers be more effective in their work. In this episode, we're discussing bipolar medicines. So we are moving right along, and we've reached the part of the presentation where we're going to talk about bipolar medicines. Now, again, you should remember that the medicines we've talked about in the antidepressant chapter and also the anxiolytic chapter can show up in the treatment of bipolar, which we're going to discuss a little bit of, but bipolar is a very special mental illness, and so it does require its own special suite of medications. As we did with anxiety and depression, I want to take a second to just reflect together on the differences in the severity levels of bipolar disorder. Can you describe the differences between what we might call a manic episode or a hypomanic episode, which is very much part of how we define bipolar 1 or bipolar 2? So, things to keep in mind is that both manic and hypomanic episodes have some of those same basic symptoms. They have inflated self esteem and grandiosity, decreased need for sleep, like they're feeling fully rested after an hour or two. People can be more talkative than usual and have a pressure to sort of just keep talking. They have that flight of ideas or subjective experience. Their thoughts are racing. They're highly distractible and easily drawn to external stimuli. They also become more goal oriented, more motivated. They're out there tackling all the world's problems. They become excessively involved in activities that have a high potential for painful consequences. So all of those things can coexist in both sides of this. But what you need to remember is that hypomanic, by definition, means submanic. So it's like diet mania. And the DSM points out that hypomanic episodes are not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. But keep in mind, if there are ever psychotic features as part of the presentation of what your patient's going through, that is always by definition a manic episode. The first medicine we'll talk about is the classic medicine for bipolar disorder, lithium. Now, what's neat about lithium is that it's just lithium. Like you go out to your high school periodic table of elements that you remember learning about, and there's an element on there that just says lithium. And that's what this is. It's not very complicated. It's just lithium. So anyway, it was first used in the 1970s, and in the beginning there was a lot of fear that it was causing cardiac side effects. But today we do have a lot more data that shows us that it is overall safe, though of course, like all medicines, long-term use can have some side effects, but we're not worried about those cardiac events the way we used to be. So today it's considered a first-line treatment for bipolar disorder, and it has a very high success rate of almost 80% in some cases, where it's treating that mania or depressive episode. However, lithium can be tricky to use, and a lot of doctors want to monitor it with blood work regularly because the therapeutic window is very narrow. That means the effective dose between what's going to work and what's going to kill you is a little too close for our preference, so it's something that doctors usually monitor with follow-up blood work, and it can also take 1 to 2 weeks for full effect, and it can take several months to find an actual balance where your patient's benefiting from it long term. The next category of medicines are anticonvulsants. And that might catch your eye and you think, wait a minute, anticonvulsants, that's like a seizure medicine. Exactly, they are. They are anti-seizure medicines, but the FDA has approved them for the treatment of mania. So you'll see these out in the world with most of your patients. Yes, you're usually going to see lithium as that first and primary thing, but long term, we tend to see more of these. So one of them is Divalproex or Depakote. This is considered a first-line medicine for manic and mixed episodes. Another one is carbamazepine. I always mess this one up. Carbamazepine. That feels right. I usually just call it Tegretol. Second line for manic, it's a first line for mixed. And lastly, lamotrigine or Lamictal, which is a first line for bipolar depression and second line for rapid cycling. So again, a little bit of therapist commentary here. You are going to see patients with all three of these, not at the same time. They tend to just be tried out and seeing what's going to stick to that patient and what's going to be helpful for them long term as the physician is measuring what their episodes are like. This is where you are very crucial as a monitor of what the patient's going through, because you're tracking things like what kinds of episodes are they having, how long do they last, how quick is the cycling between them, how serious are the depression episodes, what kinds of behaviors are we noting that the patient is doing. And as you're tracking that information, hopefully that's feeding back to the physician or the psychiatrist who's prescribing, so that we're making sure we're getting these patients the right medicine for what they're going through. So a moment ago, we talked about how anticonvulsants, seizure medicines, are used to treat bipolar, but also antipsychotics can be used as well. And in a little bit, we'll talk about different kinds of antipsychotics, but for now, you should know that second generation antipsychotics can be pretty effective. They tend to be used as a primary treatment for acute and mixed mania. And let's try saying some of these names: aripiprazole, asenapine, cariprazine, olanzapine, quetiapine, risperidone, and ziprasidone. The ones that I tend to see most often prescribed are olanzapine, quetiapine, and risperidone. Now you should also note that fluoxetine can be combined with lurasidone, quetiapine, or olanzapine to treat bipolar depression episodes. And lastly, that side effects can include seizures, cardiac arrhythmias, hypertension, metabolic syndrome, which is increased weight or type 2 diabetes, and hyperlipidemia, which is like increased fat cells. So all of these realities can be important to note, but what you should know is antipsychotics can be very important, especially if somebody's dealing with manic episodes at that higher level. And this is also a very important medicine because it can interfere with that acute episode as it's happening. Now, earlier we talked about how antidepressants and anxiolytics might still show up in the treatment of bipolar disorder, but you should actually know that they're somewhat controversial when prescribing SSRIs or things like that. Any antidepressant is a little bit difficult to bring into the treatment of bipolar. The reasons for that are that some studies show that there's a risk of triggering a manic or hypomanic switch. You certainly don't want a patient who's dealing with hypomania and depression switching over to mania. That would be terrible. And it can also increase their cycling. Now, when it is prescribed, we usually see that they are those classic selective serotonin reuptake inhibitors or that atypical bupropion, which we talked about earlier. Some things I want you to keep in mind when you're treating your bipolar patients. First, you need to understand that they will miss their mania. That hypomania, that mania gives them incredible confidence. It feels like a superpower. It's addictive like a drug. It is a euphoric high where they are creative and powerful and confident. And that's something that when they don't have, they're not going to feel special. They're going to feel like they've lost a piece of themselves. So what I've noticed in my bipolar patients is that when we get them on medication long term, it can often be really difficult for them to understand that this is something they're going to be taking for a long time and or the rest of their lives. And it's also hard to take something that is actually holding them back from experiencing that natural high. And they used to rely on that high. It got a lot of things done for them. It's when they would be creative or get their jobs done or get a lot of output. But it also put them in danger. And it also had a cost of the depression that came with it. So keep that in mind, educate, support your patients, try to help them normalize the idea of taking their medication so that they can continue to be stable. In this series, we're covering the most common forms of medicine and mental health to help therapists feel confident and familiar with their work. I hope you'll use these videos as a resource for yourself or your colleagues, and I look forward to sharing more with you in the future.